Sandra all the time is here with the cold hard truth. She's the ears and the eyes for me and you. Every day, everyone want to hear from Sandra. And every time on the air, she's getting better. Tell your sister, tell your brother, tell your mama to call Sandra in the morning and in the evening. They always calling Sandra. And when they start fighting, calling Sandra. And
That's right, folks. Everyone is telling their mama about the cold hard truth. Welcome to another episode with more truth telling, more problem solving, and of course, more tea spilling than ever before. Sit back, students, grab your tea and turn up the volume because class is now in session. Call in at 936-2626 because your voice matters. Share your opinion on issues that matter the most to you. Good morning, Cayman. Happy Tuesday. How's everyone doing on this beautiful Tuesday morning? Boy, this time of year, the weather is just so amazing. My apologies. I know we had a little bit of rain on Sunday, I guess some of us, but it didn't last for long, and the weather has been still relatively cool and breezy. So hopefully all of you are enjoying the cooler months as we start to head into spring now, believe it or not, because March is right around the corner. So good morning to everyone. Thank you guys so much for tuning into the show. Got another exciting show lined up for you. Of course, on Tuesdays, we enjoy having Health City Cayman Islands join us in the studio, and they have been featuring some of the new services that are available at the Cayman Bay location. So we're going to learn today a little bit more about the NICU unit. And we have Dr. Anil and Shamari in the studio. So let's go ahead and welcome Senor Shamari. Good morning, Shamari.
Good morning, Auntie Sandy. How you doing?
I'm good. How are you?
I am unbelievable. And you know why I'm even more unbelievable? Because I have this calendar that I got from a special person that every day gives me another fact about the history of the Miami Dolphins. So,
isn't that amazing?
I thought I'll share today's fun fact.
Yes.
Three Dolphins share the team lead when they each recovered a pair of opponents' fumbles in the 2022 season. Cornerback Xavier Howard and linebackers Melvin Ingram and Jalen Phillips. So a little bit of history from as soon as 2022, which was another great team that we had. So once again, have to thank Uncle Marlon for that one.
Absolutely. I'll definitely pass the message along. But yeah, I love little calendars like that. Actually, they're fun to read every day.
But today, we have an exciting topic today. We have Dr. Anil Kalesh with us. He has over 10 years of experience in neonatal care. He's established and managed NICU facilities across India. So he's also coming in here to help us to manage the NICU area that we have. He's trained specifically in NICU care, which he has over 10 years of experience. He has advanced neonatal training from Norway. And fun fact, he's also published research papers and case studies. And a lot of people know about the prestigious New England Journal of Medicine, and he's had case studies and research papers published in that journal. So we're excited to have Dr. Anil with us at Health City for, as you mentioned, we're coming on and speaking to some of those new specialties that we have. And even though it may be new to Health City, it's not new to our parent entity, Narayana, just based on the fact of the whole range of services that we would offer in India. A fun fact that a lot of people may not know is that our parent company is the second largest private healthcare institution in India. And as you know, India is the most populous nation in the world. So obviously, The physicians that we're getting are of the highest caliber. And Auntie Sandy, we always bring the A team here in Cayman.
Absolutely.
Knowing the unique challenges that you'll have in a small island, we always make sure that the best of the best are here with us. And I brought
Fantastic.
Baby Yoda, seeing as we're talking about seeing as talking about
Oh
neonatal
my
care.
gosh.
I have a different cup for every occasion.
Yes, yes, yes. That is so funny. All right. So we're going to go ahead and bring the doc in, but for some reason, I'm not seeing a camera for him. I can bring him in, but then it's like he's pulling a magic trick on me because I don't see him there. So I wonder if he has any adjustments that he could potentially make. Okay. All right. I see you, doctor. So we're going to give him 1 second to just adjust his camera. And then we're going to bring him back into the studio. So that was weird. Like I could see him there, but it was just a blank screen. All right. Good morning, Doc.
Hi, Sandy. Good morning. Good morning,
How are you?
Morning.
Good morning. A cloudy morning today.
Oh, is it? Oh, my window, it's clear skies ahead. So hopefully it'll pass over quickly for you as well. So thank you so much for
Well, one
joining
question, Sandy. Seeing as
Yes.
it's cool outside, have you been playing on your pickleball court?
Oh, yeah, Shamari, I'm waiting for you.
Okay, I'm
Anytime you're ready.
just making sure you're getting ready.
Oh, yeah.
It's still
I
haven't-
played a little bit on Sunday, but I got to
So-
admit, I was playing like a 10-year-old. So
So
I
my
don't think-
confidence is up because my kids haven't beat me as yet. So
Yeah.
all right, I'll come and challenge you. Dr. Nell, you play pickleball?
Yeah, I'm yet to explore it. I'm the
Well, we're going to have a party soon. We'll have a pickleball party soon.
we
We'll make-
we play badmintons every twice a week in Clifton Hunter, when the Thursdays and Sundays.
Yes.
Oh, so that means you're good with a racket. You'll be on my team, Dr. Nell.
Yeah.
Ah, boy, they're coming for me. Yes, I played a little bit on Sunday, but like I said, they were kids, so I'm not going to count a game with a 10-year-old, But yes, wonderful. So Dr. Anil, the last time I saw you, you were giving me an exclusive tour of the NIC unit. And I must tell you, thank you guys so much at Health City for making additional services available for families that have, I think it's a blessing in a way to have a preemie because you learn so much about how resilient babies are. But it's also a very trying time. It's very stressful and families have to go through a lot to sort of make it through that period, speaking from firsthand experience. I know all too well how stressful it can be. So tell us, first of all, what is the definition of a preemie? Because a lot of us moms might know, but maybe there are other people who haven't yet had kids or family members, and they don't know what really constitutes being a preemie.
Yeah, thanks, Shomari, for my introduction to the crowd today. And a preemie, we call it as a premature baby. There are two different kinds. Like one is a premature baby, another one is a low birth weight baby. We have to know the difference between these two. So normally a term delivery, we call it as a full term delivery, extends somewhere from 37 completed weeks of gestation until 41 weeks of gestation. So in this window, if a baby is born, we call them as a fully mature or a term baby. And there do exist some kind of problems with these babies also, but they are totally different than what these premature or preemies exist. So anyway, anyone who is born below 37 completed weeks of gestation, we call them as a premature babies. And within this premature babies, we call them as a late preterm, early preterm, very preterm, and then micropreemies as they come down their gestation. The late preterms are the ones who are born between 34 to 37 weeks of gestation, and between 32 to 34 we call this an early preterm, and then very preterm is from 28 to 32 weeks, and less than 28 weeks we call them as an extreme preterm, and less than 25 weeks who are like still 24, 23 weeks we call them as a micropreemies. This is how the classification goes on. And the problems in each of these cohort are widens, and the problems they face are totally different. And the number of hours they spend in NICU are totally different. And the number of challenges we face in each of these cohort are totally different for us.
Wow. So it's so good to know that distinction. Thank you so much for that. And once in my case, obviously, the decision was made to have a C-section ahead of full gestation because there were concerns, my apologies, about the baby's development. So, my physician at the time, which I always thank him for that amazing decision because I think it was the right decision, was like, listen, you've got 4 weeks left. I don't think that we are going to gain much in 4 weeks in terms of growth, but the risk that you might be undertaken in the 4 weeks could be significant. And we don't want to have to go into an emergency cesarean situation and potentially have further complications. So it was decided to go ahead and take the baby at basically a month early. And so I guess, these are some of the reasons why a baby can be premature. Are there other reasons? Like sometimes can the baby just not remain any longer and it becomes an emergency cesarean ahead of the full term?
Yeah, that's a very apt question that everyone should know as a mother or a family. So if any pregnant female can deliver a preterm baby, the global incidence for a preterm baby is approximately like somewhere between 9 to 10%. And their survival has remarkably increased because of improvement in technology. We have been getting all the gadgets around the globe to every corner of the globe. That the gadgets have improved so well that you can even vouch in on salvaging a smallest of the smallest baby now. Whereas it was quite different just 3 or 4 decades before, the survival rate was very minimal for any premature babies. Right. So now, and within this 10%, the most of these premature babies are because of these iatrogenic interventions, like baby may not be growing. On the other hand, there may be a concern with the maternal health. The mother has a very high BP or the shoot up of BP during the last blood pressure. The BP is blood pressure. In the last few weeks of her pregnancy, we call it as a pregnancy-induced hypertension or preeclampsia, or some other complications that baby may not be getting enough nutrition and is not growing at all for last 2 weeks or 3 weeks, and some interruption with the blood supply to the baby. And the most important part is any infection in the mother. Like most of them, they may have an urinary tract infection or some genital tract infection, which go on to infect the baby's fluid around the baby, that is called amniotic fluid. And any infection, like they may have an upper respiratory tract infection or a gastroenteritis, any infection in the mother, it is going to have onset of preterm labor. And best time is to have a checkup every week during the last critical weeks of delivery. You're going to see your physician now and then, so that they are the best advocates, like when is the baby coming out and when you are safe inside.
Yeah, I think that a lot of people don't really think about pregnancy and how dangerous it is for women because, we have a lot of babies, so they don't necessarily think about it. But I was speaking to my physician at the time and he said, Sandy, during pregnancy and the year after is the most dangerous time in a woman's life when it comes to dying than any other time, except from, when you're kind of like really, really old and it's going to eminently happen. And I was a bit shocked by that this is high risk, not just for babies during that period, but definitely for the mother as well. And 12 months after, there's so many things that can happen during and after a pregnancy that really takes a toll on the mother's health and well-being. So, you've got 2 patients, obviously not one, that you're having to look out for during a pregnancy situation. Now, you mentioned preeclampsia, which I think most of us know is associated with high blood pressure during pregnancy. Are there any other signs or indications that a woman might have preeclampsia?
Like there may be, the other indications are like there will be swelling of feet and there may be blurring of vision. And then sometimes a mother can throw up fits and she may land in emergency anytime. And any abnormal increase in weight gain in the mother, sudden increase in tummy size or pedal edema, and then increased frequency of micturition. These are all some of the hints that she may get, like her rings she wears in the hand, they may tighten. That may show that there is sudden increase in fluid overload in the body. So these are some of the hints that she may get. So that there may be a risk to the baby as well. So she must immediately go and concern an obstetrician for further inquiry. And the most important thing for a preemie to be born is having a previous preemie. If the mother had a previous preemie born, then there's definitely like more than 30 to 40% chance that the next baby is born to be like a preemie. I don't want to scare you with your previous experience.
No, I'm done.
This is like, this is how the statistics say that
Yes.
if the mother has delivered a preemie, 30 to 40% chance that the next baby may be preemie. Not like a sick preemie, maybe a stable one.
Ah, okay. So if you've already had one child that was a preemie, that increases your risk of having additional pregnancies where the babies are also small birth weight. And I think that the same happens with large babies, right? If you've had a large baby as well, the chances of you having a secondary or third pregnancy with a larger baby also increases.
Yeah, that is absolutely right. The average weight of a term baby actually differs from the genetics and the geographical distribution. Back in Asian continent, we call it as like 2.5 to 3 kgs. That is around like 6 to 7 pounds as an average weight of a term baby. Whereas in the West, we call them as they will be more than 9 to 10 pounds. Most of the babies we are born. So it all depends on the geographical distribution as well. And having a large baby also puts you at a risk of having another large baby next time also.
Wow. All right. So anybody has any questions, of course, don't forget the phone lines are open, 936-2626. It's such a fascinating area to learn about little preemies. And we know that they have some complications. So one of the things I was a bit surprised to hear is one of the biggest concerns is that they have underdeveloped lungs. So we see here that babies do have a higher risk, increased risk of breathing difficulties, heart problems, underdeveloped organs, and long-term development challenges. So what, I guess it depends on how premature the baby is, but in the last month, are the organs and all these things for babies still growing that much that it could be a significant concern?
Yeah, the usually up to 12 weeks where the organs are already formed in any baby. So we can make out the hands, the legs, the heart, the lungs, everything we can make out clearly in scans by even as early as 12 weeks of gestation, the organogenesis we call it as. But the maturity of these individual organs is what matters for a survival outside the mother's womb. So that's when we call them as totally survivable baby. That happens only after like 22 to 25 weeks of gestation. That's when these organs are fully developed. They may not be still able to survive without support until beyond 37 weeks. That's when we call as a fully mature baby. So between 22 to 37 weeks is what we call it as a premature babies, wherein some of the organs may be developed, some of the organs may not be fully mature. So most important thing for outside survival are the lungs, as we all know. So lungs, begins to mature from 22 weeks till 37 weeks. So with maturity, I mean the lungs, they have these alveoli, the bronchi, and there's some chemical substance called surfactant, which we are more aware of. That is the chemical which is produced in the lung cells. So that is most important for the lungs to expand and collapse during every breathing we take. So if the baby is born with this deficiency of these surfactant, we have all the structure of the lungs, the alveoli, the bronchi, everything is present. The structure is present, but this chemical is not matured. So these babies going to have difficulty in breathing. So that is the most important problem we face in all these premature babies. That's when, as soon as the babies are born, if they show the signs of these deficiency of the surfactant, we just top up them through an endotracheal tube into the lungs of these preemies. And that's when we try to stabilize them with you can see in the picture, they have been giving CPAP for the baby. And along with it, if there is worsening of it, then we give them a surfactant top up to their lungs. So that's when the risk of breathing difficulties is addressed. And slowly the lungs begin to mature. As and when the time passes after birth, the lungs begin to mature and the babies produce this chemical, the surfactant, as I told, on their own. And this problem are going to come down. And then the heart problems, almost like normally any child has almost 8 to 9 per thousand of heart diseases. Whereas in these prematures, there will be more of these heart problems, up to like tune of 15 to 20%. They may have heart problems in the sense it's not a problem that's going to last long. We have a patent ductus arteriosus, the normal connection between the vessels in the heart. They tend to stay open. They don't tend to close as in other babies. So we just have to use some of the medications to close it on our side in NICU. And the other thing is, like, if they don't still close, we have to go in for a surgical closure. It's not a really great problem that should not cause much problem for the babies. So they're all addressable in a controlled environment like in ICU. And other underdeveloped organs like the brain, they're also very, very immature, and they are prone for bleeding in the brain. And also the kidneys, we may be giving antibiotics and some of the other medications which they are susceptible to injury during our NICU or the premature stay. And if all these organs are not cared during the premature life in a controlled environment, they're going to have a long-term consequences.
Oh, wow. So can you tell me about the lung development? Because I know that, and obviously even the site can be one of the things that is very, very concerning. So I remember that, maybe a couple of days before my cesarean, I was given some sort of an injection that was supposed to help with lung development. What is that? It's the most painful injection I've ever had in my hip. But what exactly is that, and how does it work to help the baby?
Yeah, that's a steroid injection. We call it as beta-methasone injection. So it helps in, as I told, the surfactant, the chemical that is produced in the lungs. It usually, the lung cells are able to produce these surfactant beyond like 30 weeks to 34 weeks. That's when this surfactant has fully matured and produced. So if you have a threatened preterm delivery somewhere between 24 to 34 weeks, that's when these lung cells have not produced this surfactant enough. That's when we come in for this, giving an injection from externally to the mother, like the beta-methasone injection. They are given 2 doses, 24 hours apart. Then you're made to stay in the hospital, or you can be under monitoring from home. And the injection crosses the mother blood and goes into the baby through the umbilical cord, and then it stimulates the baby's lungs to produce these surfactant, as I told. And if the surfactant is produced enough, and after the baby is born, if you give some time after the injection, like 24 to 48 hours after you have received the injection, that's going to work in the baby and reduce your risk of baby getting intubated or having a respiratory support, or some of the other conditions like these heart problems and all these things. They come down if you have got these the injections before delivery. So in a threatened preterm delivery, we give these injections to the mother.
And it's so amazing that it can work so quickly, right? I mean, gosh, that's modern medicine for you. So let's talk now about some of the risk factors associated with premature birth, because I think it's important that mothers in particular know how important it is for them to take care of themselves, because a lot of these things, or I should say some of these things, are preventable from the mother's own behavior. So if the mother has a history of a premature birth, which we've discussed, is there any indication, Dr. Anil, that if a woman herself was a preemie, that impacts her having premature babies?
Yeah, definitely. The risk of prematurity also has some percentage of like 10 to 15%. It may be a genetic, like she may be premature, her mother may be premature, her aunt may be premature born. So it runs with the families. So she may have a higher percentage, like as I told. Normally, the prematurity percentage is 10% in the general population. She may be at an added risk of maybe around 3 to 5% more compared to general population. Not like if she is born premature, she's going to have 100% prematurity, nothing like that. It just adds a marginal percentage increase to her risk of having a premature baby. Not like totally go into, she will have premature. No such stigma should be there with her. And the other thing is multiple pregnancies. Like if we have 2 babies, 3 babies, sometimes even I have handled a mother who had given birth to 4 babies, like a quadruplets. So definitely they are going to be born premature. Like if there are twin babies, 2 babies, they're going to occupy the same space in the womb. So definitely there will be less space for each of them to grow. So average time of delivery of a premature twin babies, we call them up to like 36 weeks. They may not go up to like 39, 40 weeks like a single baby. So they may be coming out somewhere between 36, 37 weeks. So we should be expecting them before the time. And the triplets, if there are 3 babies in the womb, so average time they may come out is approximately like 32 weeks, because it's the same womb that's going to accommodate 3 babies. And if it's a quadruplets, like one case I have attended so far, like quadruplets, all 4 babies, they were like 2 pounds, 2.5 pounds, 2 pounds, 2.5 pounds. All 4 were like 2.5 pounds. Combined together, they were like 10 pounds. So they came out like 29 weeks only. So, and all 4 of them survived, and they're doing absolutely fine. I still talk to the families, and they are in touch with me back in India. So,
Right.
So the multiple pregnancies is most important risk factor.
Yes. And can we talk a little bit about those multiple pregnancies? Because a woman has an increased, chance of having multiple pregnancies if there's a family history. But another thing that's important to know, because a lot of women now have to turn to fertility treatments in order to have children. So if you do fertility treatments, that also, as I understand, increases your chance of having multiple pregnancies as well.
Yeah, the most important reason for multiple pregnancies is increase in fertility treatments like in vitro fertilization or taking up pills for ovulation induction pills. So what happens is these in vitro fertilization, the treatment itself is very expensive treatments. The parents undergo for their infertility, and they definitely implant 3 or 4 fertilized eggs, we call it as a zygote, into the womb, so that there will be always 2-3 ovomes implanted. And then after they mature, so that they don't take chances of failure, because if we implant only 1 fertilized egg, there will be high chances of failure. So they purposefully they implant 2-3 fertilized zygotes into the mother. And then that's when, like, if they are growing well, then they may do for a selective reduction of one of them. If they always usually go for a twin pregnancies only, or a triplets sometimes maybe. And the other thing is the genetic risk. Like if your mother is a twin, and if your sister has a twin, there's high risk that they are going to have a twin pregnancies in her, but not like absolutely must and should have. So it just increases the risk of having multiple pregnancies. And these multiple pregnancies, they are going to double the risk for the mother. Like she's going to have double the risk for preeclampsia, double the risk for gestational diabetes mellitus, double the chances that they may have vomitings during the first trimester, double the risk of everything, multiplies into times the number of babies for having all the complications she has in pregnancies. So there may be the other complications in the babies, like if there are monochorionic pregnancy, there may be chances of blood mixing with the babies inside. So these will be taken care of if there are any problems by a fetal medicine specialist.
Very interesting. All right. So we have high blood pressure, which again can lead to things like preeclampsia, which can actually be very deadly. So that's something that you have to watch. And how can you control, high blood pressure during a pregnancy? What can a mother do?
It's actually the molecular level we have to be sure of. Some of the, like, even in early scans, she may be getting a hint that she may develop preeclampsia in the future weeks. Only after 28 weeks, it's the risk of preeclampsia. Thankfully, it's not in the early times. If she's already hypertensive, she's hypertensive before conception itself, before pregnancy itself, there is a high risk that she will have preeclampsia superimposed on her hypertension already existing. That's when she has to take care of her blood pressures and regular checking of blood pressure whenever she has an antenatal visits, and close contact with your obstetrician will help her getting to know that her blood pressures are rising trend, and a good control with pills and some of the exercises and Pilates, and these are and good lifestyle changes like we are coming like the smoking or substance abuse control on that, and dietary habits and some of the exercises may help in controlling these blood pressures as well.
All right. Infections you mentioned already, and obviously one that everyone can, take into their own hands is smoking and substance abuse. So how detrimental is smoking, not just during a pregnancy, but even before you get pregnant? I understand that there's some significant concerns. If you can quit while ahead of a pregnancy, it will help. So how significant, even help you get pregnant? So what are the significant aspects of smoking or any sort of substance abuse, including alcohol?
Yeah, smoking is not just increases the risk of prematurity. There's also most important thing is smoking also leads to prematurity with a growth restriction in the developing fetus. If your baby was like was supposed to be born premature at 32 weeks, if it was supposed to weigh like 3 to 4 pounds, if you're a smoking mother, if you're a smoking pregnant mother, the baby may not grow as much as it should be in the womb. So it may end up like losing a growth of around like 1 pound or 1.5 pound that is supposed to grow. That's when it puts the baby on an additional increased risk of mortality and morbidity when the baby is born. A premature baby versus a premature baby with a growth restriction is going to be a difficult thing to handle in our NICU, even though the baby is born premature. So the complications of prematurity, as I told, the breathing difficulty, the heart problems, the pressures, the pulmonary pressures this baby was going to have after birth are high to when they are born to a smoking mother and a substance abuse mother, like cocaine abuse and marijuana and all these things. They are going to cross the mother from mother's blood to the baby, and they're going to affect brain baby, especially marijuana and alcohol. They're going to cross the mother's blood, and they're going to cause significant problems with baby's brain development. And as we all know, any developmental problems occurring in the baby during this fetal period, they're going to have a long-term consequences. They may have problem with cognitive abnormalities. They may have behavioral abnormalities as the babies grow up, born to these smoking or a substance abuse mothers. So it's not just a short-term consequences; it's a long-term consequences. It can go on for generations.
Wow, very interesting. And of course, adequate prenatal care also being a significant contributing risk factor for premature birth. Yes. Why is prenatal care so significant to keep an eye on this situation?
Yeah, the prenatal care is the adequate visits, scheduled visits. Like when you're diagnosed pregnant, you're going to get some of the blood tests, blood grouping, and your thyroid profile, and your some of the hemoglobin tests, iron profile done. And they're going to optimize. If you are in contact with a healthcare practitioner or a midwife, you're going to be your health is going to be optimized. The mother's health is directly going to affect the fetal growth. So if you have like any high risk behavior, they're going to care for you. And if you are going to be supplemented with iron supplements, calcium supplements, folic acid supplements, and some of the dietary supplements is very important. And they're going to screen you for any anomalies. The most important thing, thing they're going to screen you in an ultrasound is the anomalies in the baby. And if the baby requires any like fetal medicine interventions, they're going to refer you for a higher center. And if the baby has anything like growth abnormalities, or the baby is not growing in the as appropriately should be growing, so they're going to take care any of the other supportive measures that can be given. So if you're not having any antenatal care, so it's going to be very difficult to find out these things, because the baby is not going to be visible from outside. We cannot have a physical examination on the baby. It's only through the mother's abdomen we're going to screen the baby with the scan or the blood test in the mother. That's going to tell us about the baby's health. The baby is not available until it's born. It's not available for our physical contact. So if you're not attending the antenatal clinics, antenatal checkups as and when it's required, so we are not going to get hold of baby's health, and it's going to be difficult for us to predict the outcome. So I suggest all the mothers to have their antenatal checkups rightly scheduled and not to miss any of them.
All right. So it's important to have that information, that knowledge about what's going on with your health, as well as the baby's health. And that's how you obtain it, is through the prenatal care visits with your physician. So very, very good. And of course, you're absolutely right. Again, speaking from personal experience, that's how, I felt fine. It was so weird, Doc, that I didn't really have any issues myself. I felt just fine because, there weren't any indications that something was going on in the inside. But of course, I knew, again, that especially being an older mom, that there was always a risk of things. I needed to be very, very cautious. So thank you so much for this very, very valuable information. Now we have Jamila saying that Dr. Anil dealt with my son at the pediatric walk-in clinic and was amazing and informative. Even gave me his number if I had any questions. So again, that's at the Cayman Bay location that has already opened. So those services are indeed available there. So fantastic. So now we can talk about some of the preventative things. We looked at some of the risk, but what can women actually do in order to increase their chances of having a, term baby that is not premature and hopefully with not any additional complications. So moms, there is a lot that you can do, including regular prenatal care and screenings. Very, very important. Now, I know that some of the screenings can be very aggressive, Dr. Anil, and I wanted to ask you about this. At the time, I actually had several visits to Miami so that I could see a physician there. So now, of course, with all of the technology and stuff that you have at Health City Cayman Islands, the chances of me having, or any mother having to go overseas is lessened significantly, even in terms of the prenatal exams, right? So my physician was very, very worried, and he said, I want you to go overseas to speak to someone who can do a more thorough exam and who also had a history, a background in, familial issues, just in case there was anything else that could be picked up from a genetic perspective. So he was sort of a genetic expert. Let's talk about the expertise of your team. I know that you obviously, Shamari, told us a little bit about your individual background, but if I were to find myself, which I said I'm obviously finished, but if I could rewind and you guys are around then, is that something that you're able to do? This physician at a facility in Miami did like a very, very thorough hour-long ultrasound scan of the fetus where he looked at every single angle. Is that something you can do? Look at the health of the placenta and all of these other things as well?
Yeah, it's absolutely available at our health. Like the radiologist can do an ultrasound scan, and even the fetal medicine. We have a fetal medicine expert, Dr. Mamta, whom you intervened last week, I think, on the station. Okay. So she's a fetal medicine expert. She can go through like inch by inch of your fetus growth, and if there are any concerns about growth of any organ, like if the multiple organs are not developing properly in a fetus, that's when we suspect a genetic abnormality in the baby. So we can only diagnose a genetic abnormality by doing we can put a small needle through the abdomen of the mother sometimes, and then take out a small sample around the placenta. We call it as a chorionic villus sampling. And then at the later stage, like 14 to 16 weeks, we take out the fluid around the baby, like the amniotic fluid, through your abdomen. We call it as an amniotic analysis. Amniocentesis. Yes. So we can get indirectly the genetic workup for the baby through these samplings. And the other thing is, new advancement is NIPT, non-invasive prenatal testing. We test for the baby cells that spill over from the baby into the mother's blood. We collect the mother's blood just like a venous sampling, and then we can extract the baby cells from it and then diagnose few of the genetic conditions. But it's not 100%. It's just a screening test that can be offered to all these mothers. It can be done anywhere across the globe because we're going to take the sample and then we're going to send to the labs. It can be done even Health City as well. And then after we know it, we can, if there is any problem with the baby, that's when the question of counseling the parents about the health of the baby. So most of them babies, they're going to be healthy without any problems. If there are multiple organ abnormalities, we go for these genetic testings. We do have such expertise at our Health City as well. And after we have reports, we do have combined discussions with as a neonatal specialist, with the fetal medicine, the obstetrician. We together form a team, and then we counsel the parents like any challenges they may develop after birth with any of the abnormalities that have been diagnosed prenatally. So we do counsel them. That's the more advantage of the technology we have now. We can be expecting like what is going to come in the future.
Right.
That's the advantage.
Yeah. And that counseling is obviously important for parents to be adequately prepared for what they could be facing. Let me ask you a question about the amnio, because you mentioned that, and I know that is one way of testing for, I guess, certain genetic abnormalities. But a lot of, especially if you have passed a certain stage in your pregnancy, an amnio can actually be a very high risk procedure. So it can cause a miscarriage, is my understanding. There is a newer test that is a blood test. I can't remember the name of it now, that, parents, mothers can have that will pick up on a lot of the things that the amnio would have. Can you tell us a little bit about how that blood test works?
Yeah, the amniocentesis is not very high risk. There is some risk, like less than 1% to 0.5% risk of having a miscarriage because of amniocentesis. But when it is done under the hands of expertise, then it carries a very less risk of taking that message should be conveyed that it is not at all a risky procedure. But the other tests you told about, we call it as a NIPT, that is non-invasive prenatal testing. That is cell-free fetal DNA. We call it as a cell-free fetal DNA that is extracted from the mother's blood. For the mother and baby are connected in the womb, so baby's blood sometimes spills over into the mother's circulation, and the baby's cells will be circulating in the mother's blood. So we extract the mother's blood, then we filter the mother's blood and to identify the baby's cells in the mother's blood, and then we can indirectly test for this thing. And this test is a screening test. It's not a confirmatory test.
Yes.
We cannot vouch in because of some normality or abnormality in these tests, it's going to be baby is absolutely fine or absolutely problematic. Some of the genetic tests like Down syndrome, Turner syndrome, some of these chromosomal abnormalities can be done with that, but not absolutely. Absolute confirmatory test is you have to go for amniocentesis. Amniocentesis is the confirmatory test for everything.
Yes.
And it's not a high risk thing.
Right. Huh, that's interesting. Yeah. It's interesting that you say that, because at the stage that I was, we had done the initial blood test, and oddly enough, they said they couldn't get enough of a sufficient sample to really tell anything. And so that was concerning. And so they said, right, we can do it again, which I think we did it a second time, still the same results some weeks later. And then the physician in Miami said, at this point in your pregnancy, I would not even recommend an amnio. So unfortunately, we kind of decided to just proceed blindly in terms of that, because, the viability of the fetus was potentially at risk. So we said, you know what, let's just pray. What else can you do at that stage? And just go forward, even, if you have a baby with Down syndrome and other issues, the life quality of those children is so significantly improved now that, we're so much more educated about what that is. And a lot of babies, a lot of young people with Down syndromes and other, developmental issues have an extremely full life. So we decided that we were going to just take our chances and see, what happens. And thankfully, everything turned out just fine. But the neonatal intensive care unit, the one that you guys have there at Health City, Cayman Islands, I can tell you, is certainly the most high-tech one that I have seen. And the environment that you have to be in, because if you have a premature baby, you will know that you spend a lot of time in the NICU. I mean, it's such a stressful time. You've just given birth. You might be discharged from the hospital, but you're up and down to the NICU unit all day long. You're trying to pump and you're trying to feed the baby and you want to spend time with the baby. I mean, there's just so many components. And I was so glad to hear you say things like, Health City will be encouraging mothers to breastfeed exclusively if they can, at least in the earliest stages of a delivery, and to also have that skin-to-skin contact, which is so critical for newborns and their viability as well. So lots of things that mothers can do, picking a facility that has the requisite equipment and expert physician and midwifery and nursing expertise on hand, maintaining a healthy lifestyle. So of course, that's a balanced diet, definitely no smoking or alcohol during the pregnancy, doing your prenatal checkup so you can be aware of anything like diabetes, high blood pressure, and the onset of any of those. Now, is it the third trimester that you do the diabetes test where you have to drink that nasty liquid and keep testing? It was horrible.
Yeah, we do it 2 times. One is we advise at the beginning when you're diagnosed pregnant, get it tested so that we'll know whether you are pre-conception only or you're diabetic, because that's when it's going to affect the embryogenesis or the organogenesis. If you're diabetic pre-pregnant and your diabetes is not controlled, That carries the highest risk of problems involving the development of organs. And if you're pre-pregnant, always control sugar. If you're pre-pregnancy, if you have thyroid abnormalities, optimize it before you conceive. So planning, having set up an appointment with your obstetrician even before conception is going to be very, very important. That's when I advise any of the couples who have like recently married or who are planning to conceive, always have a visit with an obstetrician or a physician and optimize your sugars, optimize your thyroid profile, optimize your lifestyle. That's going to be affecting the neonate's health from the day one of your conception.
Right.
So get you for a full healthy body.
Yes. Monitoring signs for preterm labor, which include cramping, contractions, vaginal bleeding, etc. Is it safe to do exercise during a pregnancy? And if so, what level of exercise is recommended?
Yeah, I'm a neonatologist. I don't want to comment much on this, but you may not be able to do a same exercises which you've been doing without being pregnant. Maybe a gentle exercises just to keep yourself fit. It's always better to be in touch with an expert pregnancy or a prenatal Pilates trainer to know which exercises to be done and which not to be done, because some of the exercises, they may initiate contractions of the pelvis and they may have threaten preterm labor as well. A gentle 30 minutes walk is good enough, and some of the pelvic exercises that may help you in keeping your pelvic muscles strong for if you're going in for a normal delivery. So always take help of your antenatal Pilates expert to know which exercises to be done.
Yes. All right. Very good. Fantastic. All right. And of course, use of medical interventions when needed, such as progesterone therapy, a cervical cerclage.
Yeah.
I've heard of this before. Tell us a little bit about what that is.
Yeah, this is some of the interventions that are done if you're going to have recurrent premature babies, recurrent mid-trimester losses. Like if you're having an abortions like every first baby, second baby, third baby, there's a loss of recurrent abortions at 23 weeks, 24 weeks. And sometimes if you have infertility treatment after some 5 to 10 years of marriage, you have conceived after fertility treatment. So that's when the obstetricians, they go for a cervical encerclage. And if your scan shows the cervix length is very small, there are certain criteria which the obstetricians decide. And to stitch the cervix, the opening of the uterus, we call it as a cervix. That's when, if it opens up, the delivery is going to start the process. They're going to stitch this opening of the uterus so that there is no threatened mid-trimester abortions. So that's when you're going to push the pregnancy or the conception for a longer time. And then they're going to open this stitch before the time of delivery. They're going to open the stitch, and when it's time for delivery, and then they'll allow for the normal delivery to process.
So incredibly fascinating. Shamari, are you learning a lot this morning? I sure am.
Definitely learning a lot, but as just like you, I don't expect to have any more. So
yes, we are done, but it's fascinating to know. And Shamari, your boys, they were all full term. They look like they're strapping young men.
Yeah, they were all full term. All of them were breached, so we had to go the C-section route for all. The second one was the one who fooled us. So went through all of the Lamaze classes and and everything, and then he decided to turn around and become breech, like just at the last moment after I finished that last class. I realized that we weren't going to need it, but yeah, no, definitely excited that we're here at House It In, knowing other parents such as yourself.
Yes.
It was very interesting in that hearing the percentage of babies that are preemies, Dr. Anil, because as we gave tours prior to the facility being fully open, I was surprised at how many people either the ladies themselves had preemies or knew somebody who had a preemie. Of every person we gave a tour, maybe 40% of the people kind of knew somebody or went through it themselves, and I didn't realize that the percentages were so high. Always knew that for the cases, we needed to fill the gaps while we were bringing the service here to the Cayman Islands, not only for local parents, but also for parents overseas, understanding the $1 million babies, as they call them, if it has to go up north. And the great thing is, because we're right there in East End and so confined that a lot of people don't realize how many babies, even prior to having NICU services for instance, cardiac surgery, we would get in East End, right? Hundreds every year from overseas are flown in for cardiac surgery because obviously that was the specialty we had before. So even with the NICU services, obviously we're going to be able to help the local community that they won't need to go overseas. But even more so, we'll also be able to help the surrounding Caribbean and Latin American friends and brothers and sisters that we have there that will fly their babies in, or the mothers to us to have the high risk pregnancy, delivery, etc. Right there at Cayman as well.
Yeah, fantastic point. So Dr. Anil, we see here that one of the things that the NICU does, it obviously provides a very safe environment for the preemie babies to give them, the optimal chance of developing properly. And I know that there's a protocol on how you decide if a baby can be discharged from the NICU, and we're going to talk about that here in just a second. But you're providing respiratory support, feeding assistance. So yes, my little one had a little feeding tube in because I guess if you're a preemie, the chances of you being able to, suck properly is diminished as well, right?
Yes. Yeah. In NICU, we care them in a special environment. The challenges these neonates have, it's totally different from the other older kids. The more premature your baby is, you're going to have all the structures in the body, but they're not going to be mature enough to function in an optimal way. You're going to have the gut, you're going to have stomach, you're going to have intestine, everything in the body, but they're not functioning to the optimal level. So that's when we have to, less than 28 weeks baby, there's going to be everything, but it's going to digest anything if you're going to give the food. So we're going to keep them in a total parental nutrition, a lipid and a protein mixture that comes pre-prepared. We're going to inject them in the blood directly, the protein and the lipid goes into the blood. So as and when they cross gestation, we're going to slowly challenge them with milk, small amount of milk, and gradually we increase from 2 milliliters, 4, 6, 8. So every day we prime their gut and increase their feeding tendencies. And then also we're going to stimulate their oral cavity and their muscles. We're going to train them to swallow, suck and swallow. So if you're going to put these babies directly onto the mother's breast, they're not going to have the suckling action that the pump, the mouth and the oropharynx have to make to generate the pressure to suck the milk out of mother. So that's when we help the mothers. We give them a breast pump in NICU here in Health City, and we're going to give the express milk to the babies via syringe, sometimes through an tube placed via the mouth into the stomach. So most of these preterm babies, until they are 32 weeks, they're going to have this tube placed from the nose to the stomach. And then that's how feeding is done. And gradually, we're going to stimulate them to have a transition time of 1 to 2 weeks. Beyond 34 weeks, whoever is born, we can directly give them with a spoon. And then after some 35 to 36 weeks, we can allow them directly to suckle at the mother's breast. And that's when they have enough power in their muscles and the pharynx and the glottis to swallow them. Most of them, they have no coordination. They may have all the structure. They may not suck, swallow, breathe coordination. We're going to call them as the baby has to suckle and swallow the milk and then simultaneously have breathing movement. So if we don't have this suck, swallow, breathe coordination mature, they're going to have asphyxiation and they may aspirate the milk and they may have breathing for problems. So all these things are very meticulously assessed every day by our nurses and also the attending doctors ourselves. And then we take the right time to feed them in the NICU. And the temperature regulation is also very important. You're going to keep your babies warm because inside a mother's womb, the baby is constantly set at a temperature of 37 degrees. Of the mother's body. So once they come out, the room temperature may be somewhere 25, 28. So we have to keep them in the incubators. We have class of our Draeger incubators here in NICU installed, and they're going to take care of the temperature of this baby. And and the baby is going to grow in a controlled environment.
Yes. And temperature regulation is extremely, extremely important when it comes to preemies in particular.
And you may also be aware of the kangaroo mother care. The kangaroo care the mothers are going to provide when they are preemies born. and we are going to involve that's most important. It's not just the mother that's involved after the care of these babies. The whole family needs to be involved in the care of these preemies.
Yes. Wow. All right. So incredibly amazing again. It brings back a lot of memories, certainly for me, the importance of the NICU unit and all of the amazing support that the nurses and physicians have to offer there. So, the NICU significantly improves the survival rate of preemies as well as their health outcomes, as Dr. Anil said earlier, through advanced technology and expert care. It advances in neonatal care can lead to a very, very high survival rate with babies now born as early as 24 weeks. You mentioned 1 pound when we were doing the tour, and I can't imagine what a 1 pound baby looks like, because I can tell you that my daughter was 4.1, and I was like, oh my gosh, she's so tiny. I didn't even know what to say or do, or it was just like shocking. I'm gonna show you guys some pictures to kind of put it in perspective. Maybe some of our audience members haven't really seen a preemie, but they are tiny. And look at this. This was her in the NICU.
So
4'1". Yeah, she had a lot of hair. Everybody was like, where did she get all that hair from? So that was her, and she was smiling. This was like one of the first times we pick her up. We know that babies don't intentionally smile, but funny enough, when she heard her dad's voice, she did put that little smile on her face, which we thought was so amazing. But look at how tiny she was.
Oh.
Yeah, 4.1, but she was just really, really small. And now she's still tiny, to be honest, but absolutely thriving and doing amazingly well. So I want to encourage any mother who is going through this to know that with the expert care that's available at this amazing facility, you'll have the support that you need. You'll have all of the knowledge that you need to really make medical-based decisions on behalf of your little preemie. And the support, you've got to have support in your life. So I thank Marlon so much. He was there just as much as I was in the NICU doing the visits. And it's important to have that support around you as well. So Allison says it's imperative that a neonatal baby also conserve their energy for weight gain, and feeding burns their energy. So you're absolutely right, Allison, about that. So they know what to do and how to help these babies grow. So the NICU at Health City Cayman Bay is actually now open. What does it mean, Shamari or Dr. Anil, when you say it's a level 3 facility? What does that mean?
So based on the expertise and the facilities available, these NICUs are divided into level 1, level 2, level 3, and level 4 facilities. So level 1 facility is just you give some of the injections, that almost like the baby who is with the mother. So nothing much different happens. Like you're just admitting there for a monitoring, just sugar monitoring. You just have a few sugar and some of the injections, IV injections, like antibiotics once in a day or twice in a day. And most of the time the baby stays with the mother. And the level 2 is if the baby has some breathing difficulty, you may give some CPAP or an oxygen to the baby. And then after 1 or 2 days, you're going to be sending them back to their mother's side. And level 3 facility is where you handle the sickest of these newborns, like who are requiring absolutely terrible breathing problems, like who require ventilators. We have ET tubes, and then those neonates who have blood pressure fluctuations with shock, we call it as shock, and severe sepsis, and then who are going to have multiple lines into them, and then who have undergone any surgery, like the cardiac surgeries they have undergone. And that is where we call it as a level 3 facilities, who are going to be really, really sick. And level 4 and above facility are those babies who are on ECMO, like extracorporeal membranous oxygenation, wherein we put an additional machinery to support their lungs and the heart. The outside the machine, which is taking care of the heart and lung function. If that function is available, then we call it as a level 4 NICU. We are going to use it for the babies who are having cardiac surgery. So we can use the level 4 thing in our attached level 3 facility already present. If there is a backup needed, we have an ECMO machine, which are currently using on cardiac surgery babies in East End. So the unit is fully equipped to care up to like level 3 facility currently.
Fantastic, fantastic. So good to know. And again, a full team of specialists now at the facility waiting to assist you and your baby. So, make sure that you reach out to them. And
Yes.
this also means that your facility is offering prenatal checkups and stuff as well, right, Dr. Anil?
Yeah, we are gonna we're gonna attend the families. We're gonna provide them education, like what are they gonna expect once the baby is born, what support they need, especially in terms of feeding, in terms of the respiratory support the baby needs, and how many times you have to visit the hospital, how frequent should be your visit. The more premature the baby is born, the more frequently you're gonna come to the hospital. Like if after discharge, most importantly that we discharge the baby with all the turbulence we had in NICU, and then after that they don't turn up and they're not able to identify even smallest of the problems. Most of these babies, they're gonna continue to have problems during these first few months after discharge, challenges with feeding, challenges with breathing. They're gonna acquire infection easily. If you are having a respiratory tract infection, flu with yourself, you just have separate from the baby, and they're gonna catch flu very easily. And then we have to assess them for developmental delays. Periodically, we are going to have a neurological examination checkups. And the growth of these premature babies are going to be just marginally different than compared to this normal counterparts. So we're going to address their nutritional needs as well.
Yes.
And especially the vaccinations and other stuffs also, we're going to address them when they come. And the eye problems and the hearing problems as well, that's not mentioned here. These babies are going to be having high risk for vision abnormalities and hearing abnormalities. If we don't screen them periodically, they're going to have a long-term abnormalities, like they're going to have refractive errors, myopia, and other problems, and hearing loss as well. So that they have to be screened periodically.
Yes, very good. And what is the sort of goal that you're trying to get to before you say, okay, this baby is willing to go home? I know that birth weight, or the weight, sorry, is one of the key factors, but what else are you looking for before you discharge a preemie?
First, we have a discharge checklist that is available, and if all the checklists are ticked, then we're gonna send them home. The checklist includes like various things, like the baby should have completed a 34 completed weeks. 34 weeks should be like if the baby is born 28 weeks, she's gonna stay here for 6 weeks. The baby is gone 31 weeks, approximately 3 weeks time, and the baby should be at least a 3.5 to 4 pounds weight. That's when we are going to send them. And the baby should be free of all the problems she's having. Like the breathing problem we have been admitting in the NICU, that breathing problem should be passive. And if the baby is for antibiotics or sepsis, that problem should be passive. So all the problems should be passive. And the mother should be trained in taking care of baby at NICU. And she should have an emotional support and both physical support at home. That's the most important thing we are going to look at before discharging. And then she's trained with all the CPR techniques for the baby in case if the baby needs, and she's aware of all the medications that she's going to give in the NICU, and she's going to be aware of all the follow-up visits. Only when she's trained with all these things, then only we're going to send them home. Otherwise, there's no point in having a baby salvaged, and then you risk of sending a non-trained mother or a non-trained family this high risk baby. So we once the baby is born premature, we label them as a high risk baby. So they are high risk for having any problems at home. So we have to label them as high risk, and we are going to follow them at high risk clinic.
Wonderful. All right. So again, very, very important. And I can tell you, it was always a concern in my situation. Like, we got to make sure that you're prepared as parents, and also the baby is ready to go home, because the worst scenario is to send you and the baby home, and then the baby has to come back. It's defeating mentally and other things. I know physicians work very, very hard to make sure that that doesn't happen, and they will not release a baby if they feel like there are any concerns, a preemie in particular, if they feel that there are any concerns around that. So Soka talks about how she was cycling up to 8 months. She says people would be driving by me telling me, you're going to have that baby in the bicycle. She said, not to mention climbing a chain link fence at 7.5 months pregnant. Oh my gosh. Busting a dog out of, I guess, a bad situation and putting her under my arm and climbing back over the fence. Wow. Soka, you got a different kind of genetic makeup.
Yeah, maybe.
We don't recommend Most pregnant women do that level of activity at 7.5 months. Trust me.
Yeah,
All right, Dr. Anil, thank you so much for this insightful segment on the NICU at Health City Cayman Bay. Now open, folks. Again, if you are dealing with a preemie, you can certainly reach out to them for their expertise. Even before you know that, you want to go by and make sure you're getting all of your prenatal care and examinations and testing done so that you know if there's anything that you need to be concerned about. Any final words?
Yeah, the Health City NICU is fully equipped with all the latest technology, and we have a wonderful team of nurses and the doctors round the clock, no matter what time of the day or night. We are always welcome for any emergencies, for the minor issues with your baby, and then and the babies. You can be rest assured that the babies on the island are in the care of the safe hands.
And I know, Shamari, that you'll be talking more about the pediatric walk-in clinic, but that is also now open to parents as well.
Oh, definitely. So even obviously outside of the NICU, which is the intensive care, anything you have with your young one, anything seems a little bit off, we're definitely open and with our pediatric wing right now, so you can definitely walk in, and we'll be able to see you and take care of any ailment that you may have. So Health City, once again, is just happy to be able to provide this service and all the levels of the service to get to Dr. Anil's level at the NICU if needed. But the whole range we'll be able to deal with. So if there's anything a little bit off, definitely bring your child in. And the fact that we're so close to schools now,
Yes.
we've seen throughout the day where parents will obviously go pick up their child, their young one, and bring them in as well, because they may not be feeling the best. So definitely open and ready to see anybody who would like to come and avail their service of our services at Health City.
All right, fantastic. Well, thank you so much. Really, really informative segment. Dr. Anil, again, at Health City Cayman Islands, he's a consultant pediatrician and neonatologist. I think one of the few neonatologists on island, so take advantage of that level of expertise. Of course, we saw last week that there were others who joined us who have expertise in pediatric medicine, as well as working with preemies and working with these babies. So full team of medical professionals, midwives and nurses who are extremely qualified at Health City Cayman Bay location. Thank you very, very much to Shamari and Dr. Anil. We really appreciate you guys coming on today.
Definitely.
Thank you.
And Kifra sent you a video, so I don't want her to kick me.
Here. We're going to go ahead and cue that.
I don't want her to kick me when I get back to the office.
Absolutely.
Thanks, Dr. Anil.
Yes. Let's go ahead and play this video now as well. Thank you so much.
This is where we come when we need special care. Grandpop says the doctors here take the best care of his heart. And Auntie, she's getting ready to check on my baby cousin. She won't tell me if it's a boy or a girl, because she says I can't keep a secret. They call this place a hospital, but for me, it feels like a world where people always find what they need. Grandpop's heart, Auntie's baby, and even Daddy's injury that Mommy says is just a paper cut can get special care. It's a special place where you always find the care you're looking for. You'll feel it too when you come here.
Absolutely beautiful. I love it. Thank you so much. We're going to put that in our regular rotation here on the show. So thank you very, very much, Shamari. Thank you, Dr. Annie.
Thank you.
Dr. Anil. Thank you, Sandy, as always.
Have a beautiful day.
Have a nice day. Thank you.